great to be introduced by a former alumni of our program. So excited to be here. And thank you for the opportunity to talk about our work today. Let me share my screen and get everything set up as we're getting this ready. Let me just make sure of that. There we go. Let's put it in presentation mode. And let's switch it up. All right. So it is great to be here. Glad to be in the Zoom world, but being able to connect. I see a lot of friendly faces and good colleagues. So I think this will be a great presentation. And as was mentioned earlier, I'm just going to talk for about 30 to 40 minutes, and then we'll take questions at the end. And you can also put questions in the chat as we go along. So just to ground our work, I just want to acknowledge that this is part of a larger team of people who are working with us on this topic. Here's sort of the funding that I currently have. And the work that I'm presenting today actually has been published in 3 different publications that we've done over the years with 2 great collaborators who are central to the work that we're doing in both health disparities and implementation science. Anna Baumann, who's been a co-author on many of the papers I'm going to talk about today, and Anna Stefancic, who's one of my partners in crime, I would say, in a lot of the work that we do in this space. And the work I'm presenting is part of a larger team. I just want to make sure that we acknowledge the great work that everyone's been doing for this work. Just to situate, since this is a network that I usually don't participate on, just want to give you a sense of the work that I do in our team. I'm a social worker by training, I also was mentioned in my intro by Dr. Glass, and I focus on 3 areas of work: on reducing stigma, improving the physical health of people with serious mental illness with a focus on racial and minoritized communities, and more recently, improving the health and well-being of young adults experiencing first episode psychosis. So I'm coming at it from an implementation science expertise as well as a health disparities researcher. And the work that I do is really focused on this framework that was developed many years ago by Amy Kilborn, and we've adapted it to the work that we do. Our work focuses on detecting and monitoring health inequities in health and mental health care, understanding why those inequities exist, what factors influence that, then using that knowledge to develop, adapt interventions that can address some of these inequities. And then over the past several years, really thinking about how do then we take those interventions that have been proven to be effective, how do we move them into the community? How do we implement them in that work? So just to give you a sense of sort of the work that we've been doing, and all of this grounded in community engaged work, working really closely with our partners, working very closely with our community members and our stakeholders as we move this work forward. Another critical aspect that I just wanted to highlight as we begin this, and to give you sort of where I'm coming from in this, is this great quote from Martin Luther King that I use in many of my presentation. Is also to ground the work as a social worker. We're here to do work that focuses on social justice and to really think about health not as a commodity, but as a human right, and that everyone has the right to live a healthy life and receive high quality health and mental health care in times of need. But despite the great advances that we've done in health disparity research, inequities in health and mental health care continue to persist, particularly in the United States. And this is the area that we're trying to address and work towards improving sort of the health and well-being of minoritized communities. So just to ground on the discussion that we're going to have today and be very clear, we're talking about inequities in the delivery of healthcare, which are unjust differences between populations in the access, in the use, in the quality, and the outcomes of care. And it's really to understand why those injustices occur and what can we do about it to address these differences in these areas. And I'll tell you the end of my presentation. This is the message of my presentation for the entire thing, is that we need to infuse implementation science with an equity approach, and that this can produce valuable knowledge to help reduce inequities in the delivery of care. And my whole presentation today and the publications that we've been talking about is really how to bring these 2 fields together, how to infuse equity approaches into implementation science as we move this work forward. So why are we doing this work? Is one of the things that there are common goals between implementation science and healthcare disparity research. Both of these fields have a long history of improving the quality and outcomes of services. That's sort of the heart of these fields. Both of these fields want to make treatment generalizable so that they can be scaled up, so that everyone can benefit from the best available evidence that we have. And both emphasize contextual factors and multi-level approaches, that this is not only an individual level issue, but that there's multiple forces happening here, that the context really matters in how do we bring interventions into practice and how practice informs interventions. And that we need to consider this at multiple levels, from the individual all the way to society and every aspect along the way. However, there's a huge gap between these two fields that we have noted over the years. And that this gap continues to persist. And if we don't integrate the fields, we're going to continue to have serious issues in trying to address inequities and moving the science of implementation science forward. And some of these gaps have to do with some dangerous assumptions that we've identified, as well as others in the field. One, that all you need to do in order to address inequities is that we just culturally adapt every intervention. And in a sense, that's an important aspect, but it's not enough to just culturally adapt interventions. From the health disparity side, Jennifer Alvildres from the National Institute of Minority Health and Health Disparity wrote a really interesting piece many years ago in the American Journal of Public Health of the challenges that are happening in the health disparities field, where we're getting stuck in the efficacy effectiveness loop, which means that we focus on testing intervention in all these different minoritized community without actually getting to implementation, and that we need to move the field forward on not only testing the effectiveness of intervention, but really how do we take those interventions that we know are working and moving them into the community and really thinking about how to address that. And then lastly is this assumption of the one size fits all, that all we need to do is just scale up intervention and it will improve everyone's quality of healthcare for everyone. And in a sense, that one size fits all approach is something that I'm gonna sort of address during this presentation, and seeing that a one size fits all actually is not a great way of doing our science and moving this work forward. So in the work that we've been doing, we've been addressing this issue of reframing implementation science to address health inequities by bringing an equity lens into this process. And for this, this is one of the best pictures that I can think of. This is from the Robert Wood Johnson Foundation. And as you can see here, the framing here is that equality focuses on providing everything the same thing without considering their specific needs, their circumstances, their preferences. And what we need to address inequity is actually to address an equity approach that you can see here focuses on providing people what they need to be successful. A one size does not fit all to address health equity. We may need to do different things. We may need to tailor our approaches, interventions, or implementation strategies to address these complex determinants that shape healthcare. We may need to think very carefully about how to explicitly tackle the unique needs of a historically marginalized community and figure out what elements do they actually need. And that's sort of the lens that we want to bring into this work for doing that. And to do so, what we've done is we laid out 5 areas where we think implementation science and health equity can come together as a way. And this is not the solution to all the problems. I don't want to sound like that. It's actually the beginning of a dialogue on how do we bring equity approaches into implementation science. And these are 5 different areas we can start doing that. But there might be many others, and others have begun to write about this important topic in the field and begin to do work in the field. So to ground us on these 5 points, what we did in the work is actually take an implementation science framework that is well known in the field and see how you embed equity elements into it. God knows we have plenty of implementation science frameworks in the field. From my perspective, we don't need another one. We just, from my perspective, what we do need is how do we take the existing frameworks that we have and actually apply them and test them and begin to think about how equity actually can be used within them. And so that's what sort of the point that we made in this paper is really taking an implementation science approach here from Ilona Proctors and colleagues and embed equity into it and showcase how equity can be used within this particular framework. So the first point is that we need to focus on reach and inclusion from the very beginning. And this is a long-standing problem that continues to persist to this day. And I'll give you some evidence here of why this is such a problematic issue. The number one thing is that we see lack of underrepresentation of minoritized communities in the clinical trials that are being generated to develop the evidence that we want to implement. Here's a great example from Santiago and colleagues that they looked at the representation, in this case of Hispanics, in clinical trials for common mental disorder between 2001 2010. And for those of you may remember, 2001 was when the Surgeon General's report on mental health care came out. There was a lot of work being done about addressing inequities in mental health care. So in this paper, they wanted to trace what happened after that report came out, changes in NIH came in, and what's the representation that you have. And what you can see here is really serious underrepresentation of Hispanics in the clinical trial for both pharmacological treatments as well as psychosocial treatments for this disorder, and in some areas where Hispanics are well underrepresented. More recently, this is a great study that was recently published in the Lancet on looking at representation of racial and ethnic groups in 20,692 US clinical trials. This is from clinicaltrials.gov data, and examining sort of the median representation of the population in those trials to the US population. And what you can see here is, again, an overrepresentation of non-Hispanic whites in these clinical trials and a consistent underrepresentation of minoritized groups in the clinical trials. And this continues to impact the field. Why is this so important? In the work that we've done, we've also documented this in the physical health people with serious mental illness, both in lifestyle intervention, peer-based health interventions, as well as psychosocial interventions for smoking cessation for people with serious mental illness. And the exclusion of historically underserved communities in clinical trial creates a serious blind spot, not only to the treatment side, but on moving that science into practice. We need to do a much better job of testing this intervention, engaging communities of color into these trials to see if this evidence actually works there. And if it does, how does it work, and what are the benefits? So in our point that we wanted to say here is to focus on reach and inclusion from the very beginning, is to think very carefully of equity requires a thoughtful attention to the reach and representation. Who's invited and included into a study? Who's participating and engaged? Who are we missing from implementation studies? And to think very carefully about the communities, the settings, the providers and clients that are part of our study. How do we sample and represent the routine practice settings that will benefit most from this intervention? To think very carefully about those elements. Our second point is to think about and reformulating how do we go about designing, adapting, and selecting interventions, and thinking about how to do that with implementation in mind, thinking about where is it that these interventions are going to be used, what is the context of practice, and help that process inform the development and adaptation of interventions. So this is about reconfiguring the intervention development process. And as Dr. Aaron Lyon has mentioned in great publications that his team has done in patient-centered design, is that this linear process of intervention development faces an inherent disconnect between the design context and the implementation context, which leads to treatments that are often not feasible, acceptable, or useful in settings and communities that are under-resourced, that there's not a fit within the realities of clinical practice. So as we're thinking of designing and selecting intervention with implementation in mind, we need to think about the partners of the stakeholder from the very beginning. Who are the end users, not only the clients, but the providers and the agencies that will be using this intervention, and then the ecology of practice, the resources, the infrastructure, the financial components that play a role in how these interventions are done. And I've been trying over the past, for this type of presentation, to bring a new figure to address this, and I haven't been able to come up with one, but I'll give you some examples from our own work on how we've put these ideas into action. And this comes from our work that we've done with people with serious mental illness in trying to address their physical health. And what we did here in a trajectory of project is we start with that implementation implementation in mind from the very beginning by starting with a participatory approach. In our project, we use photo voice, which is a participatory action research approach that entrusts people with cameras to document their everyday lives and inform their social action. And in this particular study, what we wanted to do is get a sense of how are people in supportive housing agencies, what do they think about their physical health and wellness? What do they want around this issue? How can we help them with those components and use cameras and the stories and the voices behind those photographs that people are taking in their everyday community to help us inform what type of interventions we can then bring to this component. This methodology is intended to enable us to see, to hear, to understand how people make sense and meaning of what matters most to them. It relies on photograph as well as the stories for enabling people visions and voices to surface in order to inform a social action, in this case, an intervention. What we learned, and this is sort of the aims of the Health and Wellness Photo Voice Project. This was done many years ago in New York City. And what we found from this particular project is that Photo Voice generated really important information about the client's preferences for health intervention. They wanted a format of the intervention that was peer-based. Bring people with lived experiences as the interventionists. Don't bring those professionals. Bring someone who has walked the walk, who has talked the talk, who have really focused on how to improve their health as they're living with serious mental illness and substance use issues. They want an intervention in the context around weight loss and physical activity, like many of us want, and are trying to address our physical health, that they want an intervention that focuses on that. And then the methods of the intervention is not to lecture people, but experiential learning, skill acquisition. How do we make healthy choices in difficult environments, living in poverty? How do we make those choices and teach us how to develop those skills to do so? So these participatory methods were super important for grounding our intervention, the selection of intervention, and then going ahead and adapting and testing. And that's sort of what we've done in a series of studies overall. But this idea of thinking of implementation from the very beginning was really critical for the selection of our intervention and then how we went about adapting that intervention. I'm happy to talk more about that particular project in the Q&A. In terms of implementation, we have interventions that can address inequities in health and mental health care. So we need to implement what works and think about the implementation strategies that need to surround those interventions as we're trying to implement. And the best example I can think of implementation strategy is like, or the best definition that I think of implementation strategy. Implementation strategies are actions, are basically the interventions for our interventions, the things that we need to do in order to get that intervention integrated into our routine practice setting. What are those things that need to happen? And we do have interventions out there that can address health inequity. Here's some example. I want to point out one from the Decipher, which is an NHLBI initiative of 7 clinical trials right now, actually implementation trials that are being tested right now, where they're putting these questions into the test. They're really examining 7 different clinical trials, focusing on testing implementation strategies and whether those implementation strategies and intervention actually reduce inequities. Most of those studies are around cardiovascular disease in multiple levels. There's several of them actually in smoking cessation in minoritized community, but they're really pushing the work forward on funding long-term effectiveness implementation trials around this component. It's a really fascinating initiative if you get to see it. And so please check this website out on ongoing studies that are happening at this point. And it's a really interesting investment that NHLBI is doing to address inequities in these areas, looking at implementation science and health disparities research. So in terms of implement what works, we need implementation strategies, those interventions for our interventions, and in minoritized communities to bring a health equity perspective. This implementation strategy, we think, need to have these 3 elements. They need to focus on increasing trust and partnership and ownership of the intervention and the approach with the communities that we're working. This is where engagement with those communities become really important. These strategies also need to build capacity and resources and networks to help under-resourced communities actually do this work, and then focus on cultural and structural competency as potential approaches to address this. Those are recent publication, actually a special issue in Translational Behavioral Medicine, and I'm pointing out this particular scoping review where they look at implementation health-focused intervention in vulnerable populations, examine what were the challenges of implementing these interventions using the consolidated framework of implementation research, and they then map those challenges to existing implementation strategy and came up with a list of potential key elements for implementation strategies. And they are parallel to many of the points that we've made already. Identify core champions, assess the readiness, and identify barriers and facilitators for implementation, capture and share local knowledge, conduct needs assessment, develop formal implementation plans that are tailored to each of the agencies, promote adaptability, and build coalitions to support the implementation of practice. So really interesting approach. And I think we're going to see more and more of this list, systematic lit review, examining interventions and the impact that they have on implementation and how do we address some of those challenges. The fourth point has to do with continue to develop the science of adaptation. And this is something we have written about quite a lot. One of the aspects of implementation science is that implementations requires mutual adaptation. Nothing rarely fits perfectly in a different context. Evidence is generated in one place and then is always translated somewhere else. And in that translation, there's a mutual adaptation that needs to happen. The intervention may need to be adapted and the context of practice may need to be adapted. So there's this mutual adaptation of issues that need to come into play. And there's a science on how to go about adapting that. In most of this work, people have focused mostly on adapting the intervention, the what. And there's been a lot of work being done in that and lots of things that we can learn from adapting the intervention itself. But more and more as we're doing this work, we actually have discussed and begin to lay out that the adaptation actually needs to be a broader sense, not only the adaptation of the intervention of the what, but adapting also the how, the implementation strategy, that we need to think about adaptation in a more broader sense that goes just beyond the intervention, but also everything that surrounds that intervention and the implementation strategy. So in the paper that we've written, we are proposing that we need to expand the lens of adaptation and consider adaptation to both the intervention and the implementation strategy to understand the context. And in the science of adaptation, there's very critical aspect of examining why are we adapting. And to me, one of the papers that continues to be very relevant to this day is Anna Lau's paper that really focuses on why we do adaptations. That adaptations are done when an intervention and a population, there's not a fit. And we need to examine the social-cultural context of the population and that intervention and the threat to the social validity of the intervention. We need to examine what is being adapted and document that, how things are being adapted, and then really examine the impact of that adaptation on client implementation and services outcome. In the work that we've done, we have one example that we've done on how do you go about doing adaptations with the community by blending both CVPR principles and intervention mapping. This is an example of an approach that we use to adapt a healthcare manager intervention to improve the connection of primary care and coordination of primary care services for people with serious mental illness. And in this approach, we're bringing just basically two fields here, CVPR, community-based participatory research, and implementation mapping together to help in this adaptation and do the adaptation not in our labs, we're actually adapting with the community and having them engage in this process. With this component, we use a community advisory board, which is used a lot in community-based participatory research. And the idea of using a community advisory board is that we want to integrate both the research and the clinical and community knowledge, bring these two fields together and benefit from the wisdom that we see both from the scientific side of things, but also from the community thing. And also that this approach, the idea of this approach to build local skills, confidence, and capacity to deliver the intervention, that there's a co-creation happening here where the intervention is not the scientist, but the intervention actually becomes ownership by the community. In this approach, one of the things that we use in this approach was actually use an intervention mapping approach, where there's a step-by-step process and a roadmap of how you take an intervention and adapt it by going through different specific steps, and each step has the deliverable, there's an agenda for each step, and the whole point of using intervention mapping for adaptation is that it's a process that you can replicate to other interventions. So not only what happens with our intervention, but that this process can actually be used with others. And other teams are currently using this collaborative intervention framework to adapt their intervention with the community. So in the end, these two approaches basically is that we're using CVPR principles to help foster the collaboration and the partnership between our stakeholders. And then we're using intervention mapping, which provides the means of putting that partnership into action. The partnership gets together, and then there's a process that goes into doing that. And what had resulted from that particular project is that we identified multi-levels adaptations that needed to happen from the provider level as well as the cultural level for surface and deep level. And I'm not going to go into details of this, but I'm happy to talk about this process and what we encountered in this component. One of the important things that is happening more and more in this field is that people are beginning to document very clearly why they are adapting, what is being adapted. And this is an earlier paper that we did in our work using our collaborative intervention planning approach, where we literally adapted, but also documented very clearly the rationale for adaptation and then what we actually adapted. This is an early iteration of examining and systematically documenting the adaptations as we're doing them in the project and then being able to publish. And the idea here is that we have an intervention, and here's the adaptations that we did to our local community, in this case, for Latinos with serious mental illness. And we also adapted this intervention from registered nurses to social workers, and the reason and the approach in which we use that. And so other people using the intervention can look at our adaptations and see what else they needed to do. In terms of the documenting adaptation, there's been a proliferation of this approach, and one of the best approaches is by Sturman and colleagues, where they have come up with the framework for reporting adaptations and modifications. There's even a new one for implementation strategy, and this creates a really great framework to think about all the different pieces of how do you document adaptations, and you can do this prospectively as you're doing it or retrospectively, and this framework just provides sort of an idea of what are the things that you need to be paying attention to, or your team needs to be paying attention to as you're doing adaptations. It focuses on the when, the where, the how, what is adapted, what is the nature of the adaptation, and what is the impact of the adaptation. And there's been many different calls of continuing to document adaptations that are being done to create a database or a datum, as David Chambers and colleagues have mentioned, of really capturing the adaptations that are being done. To me, and actually I see Kelly here, this is a shout out to Kelly Ashburner and her team at Dartmouth. To me, the people who are really doing this work and beginning to think about this has been Dr. Ashburner and her team, where they're examining really important questions in the field, the relationship between adaptations, fidelity, and outcomes. We're doing adaptations, we're documenting them, they're great, but what is the relationships of the adaptation to the actual outcomes? Are these adaptations improving the interventions? Are these adaptations creating better outcomes? And these are two great examples of someone who's really thinking through this process of not only documenting the adaptation, but then linking those adaptations to fidelity and to the outcomes. And in some of the studies, the findings are a little bit counterintuitive, where adaptations that were not fidelity consistent actually did better in certain components, certain outcomes, than adaptations that were fidelity consistent for many ways. So check out this paper. These are great examples, and I think where the field needs to be moving, of linking adaptations, fidelity, and outcome, beginning to answer empirically the relationship between these important constructs. And I didn't know Kelly was going to be here, so this is a great opportunity to show her work. So in the end, we need to continue the science of adaptation, need to be more systematically follow established practices to avoid intervention drift and impact with fidelity. A common data platform, as I mentioned, of documenting those adaptations as they're being done or retroactively could be very helpful as interventions are moving to practice, and then continue to examine how adaptation can facilitate effectiveness and implementations, and actually test those approaches in historically marginalized communities. All right. And our last point is one that we're beginning to think of, which is to use an equity lens when we're thinking of implementation outcomes. We believe that what is needed here is a better integrator of these components. And an equity lens, so implementation outcomes are defined as the effects of deliberate and purposive actions to implement new treatment practices and services. studying implementation outcomes is critical, important, because if an intervention is not implemented correctly, it will not attain its desired outcomes and impact. So we need to think about those outcomes and where does equity fit within those outcomes. And as you can see here, we're placing equity sort of at the center and examine equities when we're testing feasibility, examine equity when we're testing cost, examine equity when we're thinking about fidelity. And there's been little attention on this area from our perspective, and we know little about the potential inequities in this implementation outcome. So we do need to pay attention to this component. So what we have done here is to lay out some questions for the field, which is example of questions where you can consider equity in implementation outcomes is, do organizations that serve large population of racial and ethnic minority groups achieve the same implementation outcomes in terms of, for example, fidelity or cost or sustainability at those agencies that serve predominantly non-Hispanic white? How do social determinants of health contribute to inequities implementation outcome, thinking about resources, thinking about the environmental factors that influence the operation of organizations in different populations? And then what strategies, what implementation strategy can produce the more equitable implementation outcomes among the organizations serving different populations? And I wanted to showcase this particular figure because there's a great publication by Alison Metz that came out last year that looks at elements of equitable implementation. So thinking about the process of implementation and how do you think about equitable implementation? And they laid out different aspects to this that I think is really thinking through about the components that implementation should have and how to think about equitable implementation from the very beginning and the different aspects. So great paper to think about of these factors that they have come up with. All right, and one more check on time. Perfect. And in terms of future areas of increase, how we put this together is, as we mentioned, achieve inclusion and representation, thinking very clearly about who we are including in our study, who we're leaving behind, and how to bring more communities into our interventions. Reconfigure the intervention development and refinement process, thinking about designing and adapting interventions with implementation in mind as a critical aspect. Continue to expand the science of adaptation and empirically test the impact that adaptations may have on not only client level outcomes, but service outcomes and implementation outcomes. And then a call for more investment in implementation trials, moving beyond the efficacy effectiveness loop and really trying to design implementation trials and testing implementation strategies to see how they can help reduce inequities in healthcare as an important area for the field to move forward. And a great example of that is the Decipher initiative that NHLBI has been doing. But we need more of those in different fields to address this. So that is what I have. That was pretty fast. I'm getting good at this in presenting this material. So I'm happy to take some questions and opportunity. And if anyone needs a reference, I think that I'm happy to share the presentation as well as any references that we have here. So I'll stop sharing so I can see everyone and happy to engage in a discussion and questions regarding this material. Thank you.